Hey guys, it's Medicosis Perfectionalis with a new case, but not just one case, not 3, not 10, 25 vignettes. Yes indeed, you heard it right. So go grab a cup of coffee to get yourself some extra systole, also known as premature heartbeats, and let's get started. Okay, let's start with case number 1. You guys want to be a doctor, so let's first get organized. Go get a piece of paper and let's write the 25 cases and the 25 answers that you think are right. And let's get started. 69-year-old male, non-retired farmer, he's still kicking, comes into your clinic complaining of severe lower back pain and pain in his right lower chest. He seems confused and looks pale. He coughs rust-colored sputum. His serum calcium level is 12.3. Creatinine is high. What's the most likely diagnosis? Is it Waldenstrom macroglobulinemia, multiple myeloma, Hodgkin's lymphoma, acute myeloid leukemia, or myelofibrosis? Now pause the video. We'll come back. So let's dissect that. 69-year-old farmer, back pain, pain in his right lower chest, so it's probably not a cardiac pain. He seems confused and looks pale. He coughs rusty colored sputum, which is probably pneumonia. Okay. And calcium is high, creatinine is high. So we have 70-year-old farmer, back pain, anemia, pneumonia, hypercalcemia, and probably renal failure. Okay, the diagnosis, of course, is multiple myeloma. Waldenstrom macroglobulinemia will have hyperviscosity syndrome. Hodgkin's lymphoma will have like a lymph node mass. Acute myeloid leukemia, usually the patient is younger. Myelofibrosis, I don't see. Yeah, multiple myeloma can lead to myelofibrosis, but I don't see like pancytopenia or something like that. So, or the teardrop cell. So multiple myeloma is the correct answer. Let's move on. Again, the same patient, okay, you know him. What's the most common symptom in these patients? Pause. The answer is, in multiple myeloma patients, the most common symptom is bone pain, by far, hands down, period. What's the most common sign in these patients? So let's differentiate between symptom and sign. Symptom has a Y in it, so you, as a patient, will tell me. On the other hand, sign has an I in it. I am a doctor and I will find it myself through observation or through the physical exam. So what's the most common sign in these patients? Is it bone tenderness, pallor, palpable extramedullary plasmacytoma, hepatomegaly, decreased height by several inches? Pause. And the answer is pallor, believe it or not, and it's not bone tenderness. Why is that? Because most of these, or like the vast majority of these patients, will have normocytic, normochromic anemia. That's why they are pale. Okay, why did I say farmer? Because farmers are exposed to pesticides, and pesticides are a risk factor for developing multiple myeloma. But I can't believe you. I can't believe that pallor is the most common sign. Okay, so there is a textbook in medicine called Goldman-Cecil Internal Medicine. Okay, open the 25th edition, which is the 2015th edition. Get chapter 187, page 1278. Okay, it will say pallor is the most common physical finding. So shut up. And if you don't know Goldman-Cecil as a textbook, you're not a doctor, you are a biology teacher at best. This is not a knock on biology teacher. They're very nice people, but let's get... Okay, let's move on. Question number 4. Who is your typical multiple myeloma patient? This is an epidemiology question. Okay. Is it the 25-year-old female with history of previous valve replacement? 9-year-old black boy with jaw mass, fever, night sweat? 70-year-old African-American guy, history of exposure to benzene and pesticides? 60-year-old male with heartburn, malignant B lymphocytes, H. pylori in the stomach? Or is it 50-year-old male with abdominal pain, early satiety, splenomegaly, hairy cells in the bone marrow, or the 50-year-old female with weight loss, splenomegaly, and neutrophilia, or the 21-year-old guy living in his mom's basement. Pause. Welcome back. The correct answer is C. 70-year-old. It's commoner in males than females. Multiple myeloma is more common in African American patients. There is history of exposure to benzene or pesticides. Okay, it's not A, of course. B is what? B is Burkitt's lymphoma, which is a non-Hodgkin's lymphoma. How about D? D is marginal zone B-cell lymphoma. How about E? E is hairy cell leukemia. How about the last one, F? This is what? Neutrophilia, splenomegaly, 922. This is chronic myelogenous leukemia, CML. The kid living in his mother's basement, it's a tragedy, okay? It's not a medical condition, although it's very close. Fifth question, same patient. What's the best test to visualize these bone lesions? Is it radioisotopic bone scan, also known as nuclear bone scan? Is it plain radiography? Is it the MRI or the PET scan? Pause. The answer, of course, is plain radiography. X-ray, good old X-ray is the best to diagnose the bone lesions in multiple myeloma. Why not the nuclear bone scan? Because osteoblasts were not activated in multiple myeloma. There is no new bone formation. There is only bone destruction. And bone destruction is picked by plain X-ray and not on nuclear scan. Number 6. How to detect these paraproteins in urine? By urine dipstick analysis, urine culture, urine electrophoresis, fractional excretion of sodium, or cystoscopy. Pause. The answer, of course, is urine electrophoresis. But pay attention, urine electrophoresis will only tell you the quantity of those Bence-Jones protein. It will not tell you which one is which. Is it the lambda light chain or the kappa light chain? We have no idea using the urine electrophoresis by itself. The 7th question, how to know the subtype of M protein? In other words, how to know if it's IgG or IgA, or is IgG lambda or IgG kappa? Is it by complete blood count, CMP, immunoelectrophoresis with immunofixation, serum protein electrophoresis, or ESR? Pause. And the answer is C, immunoelectrophoresis/immunofixation. It will tell you the quality, not the quantity, the quality of the M protein, of the paraprotein. Which of the following will confirm the diagnosis of multiple myeloma? Is it the bone marrow biopsy showing plasma cells greater than 10%? Or the bone marrow biopsy showing plasma cells greater than 60%? Hypercalcemia, high creatinine, low hemoglobin, and lytic bone lesions together, M spike on serum protein electrophoresis, or multiple myeloma is a diagnosis of exclusion. Pause. And the answer is, believe it or not, it's B. Why not A? Okay, more than 10% of the bone marrow is one of the criteria of diagnosis, but it had to be present with something else, such as the end organ damage. But by itself, more than 10% is not diagnostic of multiple myeloma. We cannot confirm it yet. But if the bone marrow has greater than 60% of its total volume made of plasma cells, you got multiple myeloma. No question about it. You can't confirm the diagnosis with M spike because MGUS, monoclonal gammopathy of undetermined significance, also will have M spike on serum protein electrophoresis, so shut up. Multiple myeloma is a diagnosis of exclusion. How come? A diagnosis of exclusion? Are you kidding? When you have all of these tests, you're calling it a diagnosis of exclusion? No, shut up. We're doing great. The patient comes back next day with severe back pain, loss of bowel and bladder control, palpable mass in the middle of his back. Whew. What's the best imaging modality for this emergency? CT scan of the abdomen and pelvis, plain X-ray, MRI, nuclear bone scan, or myelogram? Pause. The answer is the great MRI. Myelogram is history, okay? You flip the patient upside down and then you take an x-ray picture of it, and if you see an obstruction, you'll find an accumulation of fluid before the obstruction. This is history. Don't flip a patient upside down, okay? I'll see you in court. Stop it. The MRI will check this, because what's the diagnosis here? The diagnosis here is radiculopathy. Radiculopathy. What is the radiculopathy? Radiculopathy is a pathology of the nerve roots as they exit the spinal cord. This is different from neuropathy. Neuropathy is an injury or a pathology of a peripheral nerve, not while just exiting from the center or the central nervous system. No, it's very peripheral. To diagnose radiculopathy, you need an MRI. Which of the following cytokines is most likely to be involved in pathogenesis of multiple myeloma? Pause. And the answer here is interleukin-6. Okay, but how about bradykinin? Don't multiple myeloma patients have bone pain? Yes, they have bone pain. Maybe bradykinin is associated with bone pain, but I'm asking about the pathogenesis. What leads to multiple myeloma? What's the mechanism of multiple myeloma? And the mechanism involves interleukin-6, so shut up. Next question. Which of the following scenarios are involved in pathogenesis of multiple myeloma? Pause. The answer is B. Activation of rank via interleukin-1b, which activates osteoclast. If you don't know, interleukin-1b is also known as osteoclast activating factor. It activates osteoclast. Why not A? Activation of osteoprotegerine. No, in multiple myeloma there is inhibition of osteoprotegerine. Activation of rank L via parathyroid hormone, which activates osteoblasts, then osteoclast. No, this is hyperparathyroidism. This is not multiple myeloma. Activation of osteoblasts only. The osteoblasts are not activated in multiple myeloma, only the osteoclast that cut down your bone. Next, what would you expect to find on physical exam of lymph nodes in a patient with multiple myeloma? Pause, and the answer is, believe it or not, normal lymph node exam. It's not a lymphoma or a leukemia, it's a multiple myeloma. The lymph node is usually okay on physical exam, okay? Nice trick. Most of you guys answered this incorrectly. So if you answer this correctly, let me know down below in the comments. What is the most common site of bone lesions in multiple myeloma? Pause. The answer is your back, vertebrae. You can get nasty compression fractures leading to lesions and radiculopathy and hypercalcemia and you name it. Next, what would you see on skull x-ray in multiple myeloma? Pause. The answer is multiple punched out lytic lesions, okay? Spiral fractures, like it's child abuse or something. Small single linear fractures, that's when you're playing with your kid. Hair on end appearance, that's like hemolysis, such as beta thalassemia. Sunburst pattern with Codeman's triangle is osteosarcoma. Next question. If we calculated the difference between positive and negative ions as shown in this equation, here are the positive ions, here is the negative ions, and the result is X. What would you expect X to be in cases of multiple myeloma? Hey, is this a medical question? This looks like physics or algebra. Shut up, it's medicine. Pause, and the answer is 2. They're asking you about the anion gap, and in multiple myeloma, the anion gap is low. Why is the anion gap low in multiple myeloma? Okay. Because in multiple myeloma, there is the M protein. The M protein acts as a cation, which is a positive ion. When there is a positive ion, chloride cannot leave your body. It cannot be excreted in urine because it has to bind to this positive ion, because negative charge and positive charge, they bind together. The amount of chloride will accumulate in your body. When chloride rises, okay, if you can do math, X will be low. The normal anion gap is kind of between 6 and 12. Okay, like people differ on this, but that's okay. 2 is a low anion gap due to increased chloride. Next, 69-year-old African American patient with bone pain. Calcium is 13. There is renal failure, anemia, plasma cells greater than 10% of the bone marrow. He complains of tingling, numbness in his first 3.5 fingers of his right hand. On gentle tapping on the ventral aspect of his right wrist, it elicits pain and tingling in the first 3.5 fingers. Which of the following could be found on biopsy of soft tissue from his right wrist? Pause. And the answer is, it's A. It's amyloidosis. Okay, it's not B because this is sugar. Okay, and it's not follicular pattern. This is follicular lymphoma. 814 is Burkitt's lymphoma. The correct answer is A. There is primary amyloidosis in cases of multiple myeloma. Do we have to do the biopsy? No, it's just a question. Which of the following lab results are expected in multiple myeloma regarding calcium, uric acid, BUN, creatinine, and the anion gap? Choose from A, B, C, D, or E. Pause. And the answer is C. Everything is high except for the anion gap. You have high calcium, high uric acid, high BUN, high creatinine, low anion gap. C is the answer. You're getting tired, I know, but you can do it. What do you predict the mean corpuscular volume to be in multiple myeloma? Pause. And the answer, of course, is 90. By the way, the mean corpuscular volume is the famous MCV. In multiple myeloma, there is normocytic normochromic anemia, so the MCV will be normal, and the normal MCV ranges between 80 to 100, so 90 is normal. Next question. Which of the following lab results are expected in multiple myeloma regarding ESR, bleeding time, MCV, peripheral smear? Pause. And the answer is A. High ESR, high bleeding time, normal MCV, low formation on peripheral smear. Okay, what do you think the alkaline phosphatase level will be in multiple myeloma? Of course, in the serum. And here is the reference range. Pause. And the answer is, in multiple myeloma, alkaline phosphatase is normal. Why normal? Because osteoblasts are not activated, only the osteoclasts. So in multiple myeloma, it will be normal, 44 to 147. So of course, 50 is the correct answer. This is different from Paget's disease, because in Paget's disease, osteoblasts are activated first, then osteoclasts are activated. When osteoblasts are first activated, alkaline phosphatase will be high. Surprise, surprise. Next, which of the following is one of the complications of multiple myeloma? Pause. And let's go through them. Secondary amyloidosis. No, this is stupid, because in multiple myeloma, we have only primary amyloidosis, the AL fibrillar protein. Myelofibrosis, yes, it can happen in multiple myeloma, but let's read. High anion gap metabolic acidosis. No, in multiple myeloma, the anion gap is low. Okay, maybe normal, yes, but usually low. So this is not correct. Monoclonal gammopathy of unknown significance. No, like MGUS comes first, then multiple myeloma. So the complications of multiple myeloma is not MGUS. We are not going backwards. Okay, we're going forwards. So the correct answer here is myelofibrosis. Because if you have more than 10% of the bone marrow made of plasma cells, yeah, this bone marrow is going to be fibrosed pretty soon. Which of the following is likely found in multiple myeloma? Pause. The answer is pseudohyponatremia. If you would like to know more, okay, you can search about it, or you can ask me down below in the comments. We don't have enough time to discuss this topic, but don't forget, pseudohyponatremia is very possible in multiple myeloma. Hypocalcemia, no, calcium is high in multiple myeloma, so not this one. Hyperuricemia, no, uric acid is high in multiple myeloma. Dilutional hyponatremia, this is important. Okay, so in multiple myeloma, here's your blood vessel. Blood vessel has plasma, and the plasma have protein. So you have two things. You have water, and you have proteins. In multiple myeloma, you have lots of proteins. It's called monoclonal gammopathy. You have lots of immunoglobulin. So relative to the protein, the water is going to shrink. You'll have more protein and less water, so it cannot be dilutional hyponatremia. Because for dilutional hyponatremia to happen, you need to have more water, not less water. Got it, kiddo? Okay, hypernatremia. No, it's hypo. Next, we have the exact same patient. Calcium level is high, Sodium is 133. Okay, so please read through these lab values. Here is the serum and here is the urine. And the question is, what explains these kind of findings? Pause. This is a very good question and very difficult. The answer here is Fanconi syndrome. Remember, multiple myeloma can lead to Fanconi syndrome, which is proximal convoluted tubule defect, which can lead to type 2 renal tubular acidosis. Wait. What is the normal function of proximal convoluted tubules? It reabsorbs around 2/3 of everything. Okay. But if there is a defect in the proximal convoluted tubule, we cannot reabsorb sodium, so sodium will be low. We cannot reabsorb potassium, potassium will be low. Cool. We cannot reabsorb glucose, so glucose will be low. We cannot reabsorb phosphate, so phosphate will be low. There is no renal failure yet, okay? So BUN and creatinine are within the normal range. Urine glucose is high because the proximal convoluted tubule could not reabsorb glucose. It will end up in the urine. Urine protein, there is trace proteinuria, okay? Again, because this is not the full-blown picture of renal failure, okay? Whenever you see sodium, chloride, and bicarbonate lab results together, you should calculate the anion gap. So the anion gap is sodium minus bicarb plus chloride. Let's put in the numbers. 133 minus bicarbonate is 16 and chloride is 110. Okay, this is 5th grade math. 133 minus 6 plus 0 is 6. Wonderful. 1 plus 1 is 2. Brilliant. And here is the 1. Wonderful. So 133 minus 126 equals 7. This is a normal anion gap. And as you know, type 2 renal tubular acidosis is a normal anion gap metabolic acidosis, also known as NAGMA. We will discuss this when we'll talk about acid-base disturbance. These videos are coming very soon. Why is bicarbonate low? Because there is an acidosis. It's called renal tubular acidosis. Why chloride is high? Because the normal anion gap metabolic acidosis is also known as hyperchloremic metabolic acidosis. We will discuss this later. Hang on tight, we're very close to end. Same patient. Which of the following is the single most powerful predictor of survival in patients with multiple myeloma? Pause. And the answer is beta-2 microglobulin. Hands down. Last question. Thalidomide is an immunomodulator used to treat multiple myeloma. What is the most serious side effect of this drug overall? Not necessarily in the 70-year-old guy, but overall. Pause. And the answer is phocomelia, short limbs. It's a birth defects happened for patients whose mothers took thalidomide. It's a horrible teratogenic drug, but it's very beneficial for multiple myeloma. Okay, everything has pros and cons. It's life. You're an excellent human being. You have stayed till the end of the video, so please evaluate yourself. How many questions did you answer correctly? If you did the 25 questions correctly, you're lying, okay? Stop it. 21 to 24, you're excellent. Less than 5, it's never too late to switch careers. I really hope you liked this video. It takes a lot of time to prepare these videos, so please consider supporting this channel on Patreon. If you do that, some of the patrons will get PDF notes. All of these notes that I'm writing right now, you can get them in a PDF form. View, download, print, enjoy. Good luck with your exam. Good luck with your life. Have a wonderful day. Be safe, stay happy, and study hard.